Hi folks, it's Rob Timmings from ECT for Health, back with another, albeit very belated episode of ECTopics. Hope you're enjoying our ECTopics. I've had some great feedback recently, actually just this week. I got back in the classroom and we're doing some face-to-face education, and a few people that had never been to our ECT for Health courses were there in the seminar this week, and said that part of the reason that they decided to come and do some education with ECT for Health face-to-face was because of the podcasts that they had discovered. So thank you for the feedback. That's wonderful to hear, and it's given me a motivation to get these podcasts back up and running, because there's been a bit of a hiatus, shall we say. Okay, so what shall we talk about today? I would love to cover assessment, and particularly the assessment of pain. Very recently, I put a post up on Facebook and on our blog on how we assess pain, and just one of the strategies that I particularly like, which is the OPQRST mnemonic. So let's unpack that a little bit. If there's one thing that we can take home as a take-home message from pain assessment, and that is, pain is subjective. It is what the patient says it is. And so it's really, really difficult to assess pain adequately. The second big theme about pain assessment is that we as a group, nurses, paramedics, doctors, we really suck at pain assessment. We're just not good at it. All of the literature over the last 20, 30, 40 years in pain assessment has indicated those two dominant themes. Pain is subjective, and because of that, it's really, really difficult to objectify it with an assessment paradigm. So, what model do you use? I really like OPQRST. It's simple, it's alphabetical, and it's easy to remember. I grab a bit of paper towel when I'm assessing my patient, and I literally write down the abbreviated OPQRST, and it just keeps me on track so that I know that when I'm assessing a patient, I'm going to assess their pain the same way every time and get the data that I need for my documentation towards the end. So let's look at O. O is the onset. I want to know what caused the pain to come on. Ask the patient, how long has the pain been there? Did it just come on, or has it been there for many, many years, and this is just an acute exacerbation of their pain? Ask the patient, what were they doing right before they had the pain? Is there anything that they can think of that actually triggered the pain? With something like a cardiac chest pain, they might have been doing exertion, or a person might have had a fall. So ask the patient, what were they doing when the pain came on? That's the onset. The P, OP. The P is the palliation and the provocation, where palliation means what eases your symptom, and provocation is what provokes your symptom or worsens your symptom. Ask the patient what they do to ease their own pain and what worsens their pain. Sometimes it might be position. Sometimes it might be pressure. If they touched the area that was sore, does that worsen their pain? Sometimes by rubbing the area, they actually experience easing of that pain. So ask the patient, what do they do that eases their pain, or what do they do that worsens their pain? Is it worsened on deep inspiration? Is it worsened on movement? Is it worsened on position? These are the questions that we want to get right to the nitty-gritty of, to know how we can best position and best provide immediate comfort to our patient until we get through the assessment process. Does the patient take analgesia for their pain? And if they do, is their analgesia working? The whole reason that a person might present with chronic pain to an acute care service is that their analgesia has stopped working for some reason. And that can sometimes indicate that there's been a deterioration or a worsening in their pathology. So get to the bottom of that. So that's P. The next letter in the alphabet, Q. Q is about the quality. And the quality of the pain is really asking the patient about, can they describe the pain to you? You know, this is really difficult for a lot of people. We as nurses and paramedics, we tend to have a lot of words for pain. We tend to describe pain in terms of pressure and sharp and stabbing. And so I think when asking the patient the question, can they describe the pain, what is the quality of their pain, I think it's good to give the patient a a multi-choice question. So suggest to the patient, hey Frank, a lot of people describe their pain as sharp or dull or aching or stabbing or pressure or burning or electric or spasmodic. Do any of those words relate to your pain? Can you identify with any of those descriptors? Help the patient come up with a description of pain. It's sometimes in the description of pain that a diagnosis can be suggested or excluded. And so we know that certain pains have very, very definite descriptors. Classically, typical chest pain is a heavy, crushing, pressure type pain, whereas a respiratory type chest pain might be considered to be a sharp, a gripping, or a stabbing type pain worsened on deep inspiration. So, quality. Ask the patient what the quality of their pain is. R is the radiation and the region. Radiation and the region. Let's start with region. You want to know where the pain is. Can the patient pinpoint it? Can they point to exactly where their pain is? Or is it vague? A lot of chest pain can be pinpointed, and you would often assume, therefore, that if it was pinpointable, if I can point to my chest pain with one finger, then it's more likely to be respiratory or musculoskeletal pain. But if it's vague, if I only generally can indicate an area or a region where my pain is, then that lends itself more to something that you might think was cardiac. So when asking the patient about pain, see if they can pinpoint their pain. Radiation, the other part of R, is does the pain move? Does it go somewhere? So with certain cardiac pain typically radiates into the neck and the jaw and even into the teeth, often down one or both arms, most dominantly the left arm, more typically. Somebody with abdominal pain might have a radiating pain that runs through and into their shoulders. It's not uncommon for ladies who have had an ectopic pregnancy that's ruptured to have that shoulder tip pain. Somebody with a splenic injury might have shoulder tip pain. And somebody post a laparoscopy, when all those bubbles of gas are left up underneath their phrenic nerve, it irritates the phrenic nerve and causes referred pain through to their left shoulder tip. You may have experienced if you've ever had a laparoscopy. So we want to know where the pain radiates. Back pain occasionally can radiate down through the buttocks and down the back of the legs, and is sometimes referred to therefore as sciatic pain or sciatica. So that's my region and my radiation. The next part of the alphabet is S, and that's the severity. Arguably the most difficult part of our pain assessment is trying to get the patient to pin down the severity of their pain to some sort of a numerical analogue scale. So we've got a few different scoring systems that are available. Many of you will be familiar with the FACES scale that's occasionally used for children or people that have poor numeracy skills. So that's where you've got 5 different faces that a person can choose from a non-distressed looking face right through to a very distressed face. These scales have been tried and tested in the literature over the years, and the Wong and Baker FACES scale is probably one of the most commonly ones used, particularly in paediatrics. The other scale system that most of you will be familiar with, of course, is the 0 to 10 Likert type scale. So with the 0 to 10, this is only as beneficial to the clinical assessment as the patient's ability to understand a numeric scale. We need to be asking the question correctly and consistently every time so that when you assess a patient with the pain scale and I assess the same patient with the pain scale, we're talking about exactly the same thing. 0 is no pain at all, and 10 is the worst pain the patient has had. It is not the worst pain the patient can imagine. You can't imagine a 10 out of 10 pain. It's an unachievable number to get to. So 10 needs to be something the patient can remember, can reflect on. So when I say to my patient, on a scale of 0 to 10, where 0 is no pain, 10 is the worst pain you've ever had, this allows the patient to be able to reflect on pain that they've previously experienced. Now, when they get to that 10 out of 10 pain, which might be today, sitting in front of you, the patient might say, well, this is the worst I've ever had. And if it is, make no mistake, call that a 10 and write that down as a 10 out of 10. It's not a number they have to get right. It's not some sort of a quiz, and it certainly isn't linked to an analgesic option. A pain score is a number that we want to use as a start point upon which we're going to build an intervention. It doesn't matter what number they give you. Believe them and write it down. 10 out of 10 is the worst pain they've ever had. Now we're going to give some sort of intervention. We might position them or put a hot pack or a cold pack on them, or we might give some analgesia. We might give some simple or some narcotic complex analgesia. And the most important thing is that afterwards we'll go back, maybe 20, 30 minutes later, and we're going to reassess that patient's pain and say, now the last time that I asked you your pain score, you told me it was a 10 out of 10. You've never experienced pain this bad. Has any intervention that I've done improved your pain? And if it has, it gives the patient something to reflect back on. 10 out of 10 is the worst they've ever had. It is not the worst that they can imagine. So that's my S. The last piece of the puzzle is T, and that's the timing. It sort of links back as a circle back to the onset. Back when we looked at O for onset, we looked at what made the pain come on and when did the pain come on. Well, T for timing is similar. I want to know, when did the pain start? I want to know if the pain is long-term chronic pain. How long have they had their long-term chronic pain? It might have been months, it might have been years. I want to know if the pain, when it comes and goes, how long does it come for and how long does it go for? A person who presents saying that they had severe pain at home, but now their pain is somewhat eased, it may just be artifact. It may have just been eased because their level of anxiety has dropped, that they finally have come to a clinic where they feel that they perceive they're going to get some assistance. Their pain seemed a lot worse when they were at home and alone, but now that they're in a facility where there's, caring staff that have drugs that might be able to give them, there's a psychological impact that has changed their pain. So if their pain has reduced, when did it reduce? If their pain has gone, when did it go? And if the pain is of that nature that it comes and goes, it's spasmodic in nature, how long does it go for and how long does it come for? Are all important questions when we're looking at timelines. So that's pretty much it. Just a quick little episode. OPQRST, a nice little simple mnemonic, easy to remember when we're assessing pain. And if you're assessing pain the same way every time you assess pain, you've got a beautiful little template that you can use to document your pain in your patient's notes. Really happy for any comments. Really happy for you to jump on our Facebook page and our Instagram and have a look and see what we do. And of course, jump on our webpage and have a look at our education. So we're at www.ectforhealth.com.au, and you'll be able to navigate to the What's On page and see what's coming up in your area, or even have a look at our online education if you can't get out at the moment. We'd love to see you either in front of a computer or in my class sometime soon. Hope you enjoyed the episode. Talk to you next time. This has been Rob for ECT's ECTopics. See you guys.